current two generations of dietitians, doctors have never had to endure famine. It never occurs to them. So that, in fact, I've been in front of now, thousands of people at different times, and I'll ask, how many of you have gone a day without eating? Nobody raises their hand. Yeah, because we've had food around, nobody thinks that, well, if you don't eat for a couple of days, we all go into fat burning. The staunch anti-low carb, veggies will be happy that they fat burn it if they can't eat for 2 days.
Welcome to another episode of Born Unstoppable. I'm Thiago Lusvarghi, a first-year family medicine resident physician. And in this episode, I had the privilege of talking with Dr. Eric Westman, who is a co-founder of Adapt Your Life and Adapt Your Life Academy. He's an associate professor of medicine of Duke University Health System and the director of the Duke Keto Medicine Clinic in Durham, North Carolina. In this episode, we talk everything keto, so I hope you enjoy. Before we begin, I'd like to emphasize that this podcast is separate from my role as a family medicine resident at the University of Toronto at the Royal Victoria Hospital in Barrie, and I may cover topics that aren't fully aligned with the CPSO, our governing body of physicians here in Ontario. It is, however, part of my desire to bring awareness and information as it relates to improving health and other aspects of life at a zero cost to the general. Hi, Dr. Westman. Welcome to Born Unstoppable. Thank you so much for coming on the podcast. Would you be able to quickly share a little bit about your journey, how you got into this nutrition and obesity medicine space?
Sure. Well, like most medical doctors, and I didn't get much training in nutrition. I didn't get any training in obesity treatment. I mean, back in the 80s and 90s, that was the birth of the fear about cholesterol and the fear of fat in the food. And I maybe got a little total parenteral nutrition training in the hospital, learning about how to feed people if you have to use just intravenous feedings. But no one really was talking about therapeutic diets and the medical space. So two of my patients lost over 50 pounds each around 1998. So I was 10 years into my clinical research practice and training. And it was remarkable. I mean, nobody lost weight in my practice. I was at a Veterans Affairs hospital, which is, kind of the largest HMO in the U.S., although no one calls it that. But it was funded by the government, and the patients that I sent to my dietitians, they never lost weight. And so I was kind of an oddball because I was an internist, but I was also interested in nutrition. And because of these two patients, I'm like, well, gee. So I asked them what they did. And one of them looked me in the eye and said, all I did is eat steak and eggs. I probably leapt out of my chair backwards. But I asked him what he did. He read the Atkins book, and he had done it before. So Atkins had been out since the early 1970s. Dr. Atkins had a book and a practice. And in the 1990s, late 90s, when it bubbled up to my awareness, there was a revision and a rewrite of the book. And so I was just curious. These two patients lost weight. I thought, this is easy. You don't even need a doctor to lose weight, so maybe I needed to learn about food. And although, so I kind of went into it naive about food. I mean, how bad eating fat was, which is a good thing, because now with the 20-year lens of studies, it's not a bad thing. But, everyone else knew it was at that time. And so one thing led to another. I ended up in Dr. Atkins' office in New York City because there was no one else in a clinical practice doing weight loss medicine or diet books. I reached out to the ultra low fat diet book authors. They didn't have clinics. It was like they would write a book and everyone's supposed to do this. And then, I was starting to get wind of other agendas going on. And so as an internal medicine trained doctor myself, I thought it was really important to find a doctor who was using this every day in their practice. So I wrote Dr. Atkins a letter. He called me back, and he suggested, why don't you come to New York City and see my practice? And so I did. I took a small research team and wrote a one-page study that we would follow 50 people over 6 months and follow every parameter that we can. And that was published in the year 2002. So when someone asks me, well, what about the, I don't know, Dukan diet or the grapefruit diet or something, I say, well, get 50 people, put them on what the diet of whatever you're talking about, publish it in a peer-reviewed paper, and then I'll comment on it. It doesn't even have to be a randomized trial. There's a formality, a formal process of testing things. And I got that training through internal medicine and the processing of figuring out drug development. That was kind of my start. And so I thought, well, let's apply drug development techniques, the stepwise process, to a diet that was clearly effective. I mean, so this issue I had was safety. And everyone else around me was like, well, you can't tell people, they might have been fine at 6 months, but at 6 months in a day, you don't know. Yeah, so there's just kind of a weird reaction. Again, I was kind of totally naive. People say, well, you're such a pioneer, you were so brave. No, I was kind of the fool walking into the battle that I had no idea what these arrows were. And of course, over time, it became more obvious that I was going against everything we were possibly taught. But again, following the data was one of the things that I learned at a university called Duke University, and that's where I still am today. And they, as an NIH experimentally driven research group at this university, and I think it's different. Every school has a little different emphasis, but here it was really, data rules. And I took statistician training. I have a master's in biostatistics. And so these patients had success. I went to ask for funding from a doctor, which of course came through in one of the first reviews submitting that paper. One of the reviewers said, we're not used to looking at studies funded by doctors themselves, but who else was going to do it? Even today, the government, I can count a handful of people who are funded by the US NIH to study this, and this is 25 years later. So, there's a company, Verta Health, that did their own studies, but it's really kind of shocking and sad that the governmental organizations haven't addressed this scientifically. I mean, if they're against it, they should prove that it's bad. And so anyway, one thing led to another. We're doing randomized trials, and then Dr. Atkins creates a foundation that funds research in this area. And then after about 6 or 7 clinical trials, several of them randomized trials with low carb versus low fat, with obesity, with diabetes, with PCOS and GERD and fatty liver and irritable bowel, I just decided to open a practice. So, Dr. Atkins opened his practice in the early 1970s, and I visited around 1990. So I kind of knew what an experienced practice might be, but I didn't know. Maybe the people that died didn't come back. That's the hazard of looking at a clinical practice alone. So that's another reason to do research. And after I got reassured that I wasn't harming anyone, then we opened our own practice in 2006. So I've been using a low carb keto diet, the version that Dr. Atkins used right around 1998, 2000. Of course, he dies when they closed the practice there in New York City in 2003. So it took us several more years to get the credibility of my peers. You can't just open a clinic at a university with doing some lame brain thing. You have to have some science, at least at Duke, a university like Duke University. So, and now I've been applying low carb keto. Oh, and then it starts to be called keto. I was like, what's this? And yet we were doing studies on a ketogenic version of a low carb diet. It was called Atkins induction. But so now enter in all of what we call internet keto today, where there's this kind of irrational fear of seed oils and the idea that you should have butter all day long and butter in your coffee and other things like leaping into cold water baths and then saunas and then kombucha. And then I meet a keto guy, who talks about his portable sauna, infrared sauna that he's using in his hotel room because it's so healthy. And I'm like, oh my goodness,
Yeah.
this isn't what I studied. So anyway, it was, I think, looking back, we started studying something that really had been a taboo on studying it, meaning there wasn't any science that said it was bad.
Mm.
It was just kind of everyone knew it was bad. The taboo about, don't go over there. There's something evil, and yet Jeff Volek, one of the scientists I've known for over 20 years, at a recent meeting, got up and I always ask him in public, about it once a year. Have you learned anything at Ohio State about a keto diet that makes me that I should worry and I should stop using it in my clinical practice? So he's been doing the studies in what you would call more formal but healthy or runners or athletes, but looking at the ketogenic adapted metabolism. So he calls it keto adaptation. So he just gave a talk called the keto adapted phenotype. From the muscle point of view, he gave that at the Metabolic Health Summit. And I asked virtually, I said, have you learned anything that would say that it's bad? And he says, no. The science, there's no harm in telling someone not to eat carbohydrates as long as it's
Yeah.
well formulated, and they've come up with the language, well formulated, adequate protein diet, ketogenic diet, so it's not high protein. What does that mean anyway? There's anyway. So they came up with that language, and then it was just this last month. I'm reflecting on this. Jeff now after 25 years, me after 25 years, we're not finding any harm. When I look back, right around the year 2000, we did some reviews. So we before doing our own data-driven research, we reviewed the literature. There were
Hmm.
actually some positive studies. They were small, they were uncontrolled, but now I look back, if it was so bad, where were the studies that said it was bad?
Yeah.
They didn't exist. They didn't exist, and that didn't really hit me until recently. Like, because I'm an old paradigm guy. I mean, I remember I grew up, worried about fat and eating sugar at Halloween, mounds of it, and drinking sodas, and so to have that shift, kind of in my own world experience, I didn't. It didn't occur to me that to emphasize there are no studies that are bad.
Yeah.
Say it's bad because we all knew it was bad. And it's really more like religion, where you don't have to have a study that says there is no God. We all know there is a God. Yeah, but
Mm.
we're scientists, I thought, and so sticking to the data, doing one study after another, and then other people started to do studies. Now there are meta-analyses of low carb versus low fat for obesity, for diabetes, but our clinical experience is way ahead
Okay.
of the randomized trials. I mean, and it's really interesting. I mean, we're finding heart failure reversal in our clinic. Oh, wait, finally, the Department of Defense in the US is funding
Really?
a study on heart disease. And I think it's because of the SGLT2 inhibitors that make the urine leak glucose. They're trying to figure out, why would these drugs help people with heart failure? Well, one of the hypotheses is that the ketones generated by these drugs actually help the heart and help the heart failure. So they're kind of working back through the lens of drugs, because I've come to just realize that
Hmm.
medical care today is medication care. We teach doctors, we teach residents how to use medications. And so I'm no good in the attending clinic anymore, where if they
Right.
wanted to just learn internal medicine, because I'm just talking about diet. Diet is the most important tool we have as doctors. And yet,
Very,
how much
very
training
little.
did you get
So let me
about
let
diet?
me jump in. One of the cool things I want to note is I appreciate that when you're not only a clinician, but you have the research background and the curiosity to actually go out and do a study and get some data to then just start the cascading event of more data to be able to be done. And so you're one of those, I think, pioneers that took a step, and now I know there's a lot of research for keto, but still even within my own resident group, there are people that are skeptical of keto and think it's still a fad diet. So
Oh, well, so the white yellow book with an egg
yeah,
on it called Ketogenic, The Science of Therapeutic Carbohydrate Restriction. I wish we would just send that to every dean of every medical school in the short run. Get that copy, or I can send one to you. Let me know how to get it to you. It's $100, but it's this thick on low carb diets, and so I kind of use it as a
yeah.
almost like show and tell. Oh yeah, there's no data.
Send it to me.
I'll go through
I'll
this
leave it
book,
in our
and then, they
residency
go, oh
lounge or where our supervisors teach us. That way, we always have it there as a reference.
yeah,
That'd be good.
that's what I've done. I put it in the residency clinic office.
One
I
of the
don't know if it
things
gets
that
opened, but
I know you wanted to discuss, and I want to hear from you, is just the practical aspects. I think a lot of people can learn about the theory. There's a lot of podcasts on that, but just the next question I have is, what is a definition of a low carb diet? Like how many carbs? Because I know there's different levels, and then take me through, that description of a well formulated keto diet and what you walk your patients through.
yeah, absolutely. And so the definition of low carb kind of depends on who you talk to. Although we've had a paper out there since 2007 that gave specific specific criteria for low carb diets, and then there was a recent review that again kind of reiterated these different levels of carbs from the low carb world. And so what happens is you get non low carb people making guidelines about things, and they don't know what they're talking about really, and that's unfortunate that you ask someone who's not an expert in keto diets about a keto diet. Well, they're not going to know
Mhm.
much, and they're probably going to be against it. So a typical American or Canadian eats 200 to 300 grams of carbohydrate a day, and instead of using glycemic or glycemic load, glycemic index, which again are kind of nebulous terms, and you have to look at a sheet of paper and all of that. We use grams of carbohydrate to help people determine how many carbs to eat, and we do kind of make the uh, uh, how should I say, lumping together fructose and glucose. I don't make that distinction because, for all practical purposes, most of the things we eat have glucose in it. So even fruit, although it's fructose, no, fruit has glucose. I mean, all you have to do is put on a continuous glucose monitor,
Right.
eat a piece of fruit, and the glucose goes up. Yes, it has fructose in it too, but sucrose is glucose and fructose. The two, it's a disaccharide. So if you if you eat sucrose, table sugar, you're getting glucose and fructose, and it's endlessly confusing. And Rob Lustig, who I really love, who only could talk about fructose, got this viral video about fructose, fructose, fructose. It doesn't help the individual figure out what to have. So, in fact,
Okay.
just look at total carbohydrate, assuming, yes, of course, it's more nuanced. There's glucose and fructose and all that, but and fiber and all, no, just look at total carbohydrate on a label. In the US and Canada, it works perfectly. In Europe, however, they already deduct out the fiber when it says total carbohydrate because they ask people who don't know about keto diets how to define carbohydrate. Well, the glycemic uh, impact of fiber is negligible. No, in some people, it's quite uh, non-negligible when you have fiber. So some fiber is absorbed. So when you look at, that's my long story to say, we look at total carbohydrate in total grams, not net grams, which has now introduced this confusion with foods, the keto foods. And I instructed someone with my method recently. It's a piece of paper. Well, it's not my method. I borrowed it from Dr. Atkins, remember? And we just studied it. But I gave them a list of foods, and she came back saying, "Yeah, that keto diet didn't work." I said, "Well, what did you do?" She said, "Well, I had the keto bread and the keto ice cream and the no, 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 no. That's not the keto." So internet keto would teach you to have all of these higher total carb things using net carbs, and God only knows what they put in there. And so I said, "No,
Right.
no, no. That's not what I taught you. I taught you to avoid the keto things out there and just eat real foods. And so she said, "Oh my goodness!" She came in. She said, just give me a pill." But I said, "Well, wait, what did you do?" And I learned that after she learned that, she said, "Oh my gosh, I made a big mistake, and I couldn't afford all those foods anyway." So I talked her into doing it again, which gets to the metaphor that we use. Two metaphors for teaching. One is like teaching someone how to ride a bike. The first time you might get on there and boom, I don't even remember how I learned, but and some people, one person told me my cousin put me on the bike and threw me down the hill. And she had to figure. No, most people learn like swimming lessons. You get bike lessons, and the teacher is patient and tolerates you falling, and you might even get training wheels for a while. But again, you have to eventually do it on your own, which is doing the diet on their own. So in this case, I explained, that's fine. You just try again, reboot, and so the giving out the plan, which for me is just a sheet of paper, and saying stick to this sheet of paper, and then the follow up is really important because the internet world, the friends, the neighbors, the spouses will say the darndest things and interfere with this simple sheet of paper. So I give the instruction and then have people come
Mhm.
back to see how it works, which is really important with any kind of, if you're consuming internet information and there's some influencer, if they've never been in a clinic, they've never had people come back to
Yeah.
say, what you told me didn't work. Oh, well, so that gave me years ago that I had to go visit a clinic where they were using it and getting that feedback. I'd been a doctor long enough to know that I learned from my patients. I had one person who said, I think my drug, I forget what it is. It might have been amlodipine, a calcium blocker, and I think the drug is causing, leg swelling. And I looked it up, and I said, no, it can't be. It wasn't in the books, right? And he came back and he said, I stopped that drug and my leg swelling went away. I said, well, and he wasn't mad at me. He was just telling me, what you told me was wrong, and I learned. Right now, it's common knowledge that amlodipine can cause leg swelling. So there's a lot that's learned about drugs out there and diets, and so you give a teaching, instruction, and then you follow up to make sure it's working. And if it's not working, you make some tweaks in it. So I teach people in one sheet of paper, you can have as much as you want of the zero carb proteins, the meat, poultry, fish, and shellfish, and eggs. It's all at the top of my list, and you can have as much as you want of that because metabolically the blood glucose doesn't go up. And if the blood glucose doesn't go up, then the insulin doesn't go up. And
Mhm.
insulin is the fattening hormone. So you want to eat to keep your glucose and insulin low. So not only does insulin make you put carbs into fat, it blocks the fat burning. So I was taught years ago by Steve Finney, one of my teachers and just brilliant guy, said, you burn what you eat. So there's like a food cue called there's a respiratory quotient that you can, by looking at the oxygen and carbon dioxide that someone uses, you can
Yeah.
infer how much they're fat burning and carb burning. Well, he said it was even simpler than that. You just look at what people are eating and they're burning what they're eating. So it's like the food quotient. Because if you're eating carbs, you got to burn the carbs,
Yeah.
or if it comes out the other end, you're not burning it. But so if you want to burn carbs, go ahead. But if you're coming to me for fat loss, so obesity medicine is not just weight loss; it's fat weight loss. Then you want to not eat carbs because you have to burn those carbs. So do you want to burn fat or do you want to burn carbs? You burn what you eat. And so when people are learning, our
And the
bodies
question
are pretty
about that
simple when
is
it comes
if
to
you're
fat
eating
burning.
fat, then
It-
you're probably going to be burning the fat that you eat before tapping into your actual fat stores.
well, I think that's true, although the studies have never really been done to show to my knowledge. I mean, what you need to do is radio label something or figure out. Sometimes glycerol is used as a proxy for lipolysis in the blood, glycerol in the blood. But I assume that too, and that's just kind of the common sense that your fat weight, your bank account is it's kind of like your retirement account or savings account. You don't draw upon that until you're needing it when your energy level is above what the energy that
Yeah.
you're taking in. So, but I think that's a safe assumption. I'm just trying to be really precise because it's you guys who are going to figure all this out. I'm of course I'm never going to retire. My experiences with using this in lots of different conditions. Well, but then so one thing that's taught on the internet that gets erased or adjusted in our teaching is there's a section on my page which is high fat but very low calorie items. And so the internet teaches you can have as
Right.
much cheese and butter and cream as you want because there are no carbs, right? Well, but there are a lot of calories. So you have to have a limit to the high calorie items, and these are mainly the fats. So the cheese, creams and oils, mayonnaise. I met one person who the mayonnaise jar was a serving size. She would just blow through the
Oh,
whole. For me, it's peanut butter.
yeah.
You give me a jar of peanut butter or ice cream. I could eat a quart of ice cream without stopping, just because I was kind of conditioned that way. So the final thing on this list that we give out that kind of goes against the teaching out there is that we do let
Okay.
people have non-sugar sweeteners because the practical reality, at least in the US, we have such sugar addiction or habituation, or if the consumption of sugar is
Hmm.
so high,
Hmm.
people crave it when they stop it. You actually can give it the name addiction for some people because you get craving, there are withdrawal symptoms like irritability. And so when someone stops all of the carbs all at once, which is in essence what I tell people to do, there is a bit of a withdrawal syndrome. Some people don't have that at all, but and then the keto adaptation, you might get headache and fatigue a few days. 25 years ago, people would call me and like, I have a headache. Am I dying because I'm eating all this fat? I'm like, well, I don't think so. I mean, now
Yeah.
I'm like, no, that's keto adaptation. Your body is adjusting now to the not eating of carbs and your body burns fat. So I wanted to say, just again on that fat burning thing, everybody goes into
Yeah.
fat burning if they don't eat for 2 days. Think about it. It and it came to me when I was looking at my cell phone and it said low energy. Do you want me to go into safe mode? And I flipped things around. Oh, do you want me to go into self destruct mode? No, you wouldn't create a machine that if it's low on energy, you would let it self destruct. I mean, well, so what mammal, pretty much all mammals store energy as fat. Why would fat burning be harmful when you have to go without food? The current two generations of dietitians, doctors have never had to endure famine. It never occurs to them. So that, in fact, I've been in front of now, thousands of people at different times, and I'll ask, how many of you have gone a day without eating? Nobody raises their hand. Yeah, because we've had food around, nobody thinks that, well, if you don't eat for a couple of days, we all go into fat burning. The staunch anti low carb, veggies will be happy that they fat burn
Right.
if they can't eat for 2 days. So to me, evolutionary pressure really is designed now something called ketosis or euketonemia, where if you don't have a lot of energy around, there are certain economies that are made instead of it's toxic and there's doctors you'll find them all over the well-respected university doctors saying, well, it's ketosis, it must be bad for you. And
Yeah.
I
And it's
just kind of
different than the
laugh at that now.
ketoacidosis that they're thinking about.
Correct. Yeah, and that in their defense, they've only heard that thing keto in
Yeah.
combination with ketoacidosis. But you know, you could learn. Yeah, so I finally, after doing these reacts videos on my YouTube channel, I finally, said, look, if you want to learn about vegan diet, talk to a vegan. If you want to learn about a
Right.
keto diet, talk to a vegan.
Yeah.
I mean, talk to a keto expert. You know,
So,
Um,
one thing that I wanted to ask you is what are some common, I think you've already tackled some of the thoughts of like some misconceptions about low carb and ketogenic diets. But like, can you just touch upon people's fear of one, too much fat or too much protein can lead to kidney damage, or, red meat is carcinogenic? I think I see those ones quite often when people who are against keto or meat, they'll usually bring those up. Like when patients bring that up to you, what do you usually tell them?
yeah, well, so it depends on the level of fear or concern, and some people just want to be told, no, it's fine.
Yeah.
Honestly, so so I teach people from all walks of life, all socioeconomic levels, and some people are just want to hear that it's okay to hear a doctor just say,
Yeah.
"Don't worry about that." So one way I'll say it is in the context of this kind of diet program, because you're burning the fat that you eat doesn't cause a problem. So actually, I'm staying in my lane by saying, here's what I know about low carb and keto, not going outside where I don't know that there's
Mhm.
really any damage for anyone, but that causes the controversy. So if you only talk about this way of eating and you don't bash what other people believe, then you kind of you get
Yeah.
less friction. You're being more of a diplomat. But to the individual, I'll just explain that we all kind of grew up being taught and thinking that eating fat was bad, and there's some studies that are very small and really don't say red meat is bad. I mean that it's
Yeah.
association and not causation. Now, getting into if it's a scientist or university professor, I'll just these aren't randomized trials where you're giving people red meat and seeing if they get more cancer, for example. They're association studies, and you can't prove causation from an association study, and unless the risk is really really different. These are very very close. And then I'll say that there's actually a recent review from the scientists that say saturated fat is fine, and it takes years for that scientific knowledge to percolate through the clinical world. And even then, there's some, but what about the American Heart Association? And they say, what about the guideline? Well, the latest national guidelines, not the American Heart Association, say saturated fat
Mm.
is not a cause for concern. But there are organizations like the American Heart Association, the World Health Organizations that are influenced by things other than science. There's a lot of lobbying. There's a lot of social world, issues that it's not scientific. They still have this old view, and I have to imagine that the people on those panels are probably older and have that old belief. And so until they change, but if you build an organization based on the fear of saturated fat, like the American Heart
Hmm.
Association was
Yeah.
started, it'll probably never change. And that's okay. So you got to know what association are we talking about? What is their agenda? And maybe there are other ways to go about things. Have you ever driven in England where they drive on the left-hand side of the road?
Right.
It's wrong. Well, okay, people kind of okay. Well, maybe do you use a phone with a cord or a flip phone still? No. Who knew that you would be able to take pictures on your phone, right, or talk to other people? So keto as a metabolism is different when you don't eat carbs than a carb eater. And so there's so many things that are different. Now, most people can't understand that. They won't, and even doctors won't understand that. And they'll compare their patient to the lab test, the normal range of people who eat carbs. Well, but doctor, that's normal. Well, it's for
Right.
normal for people who eat carbohydrates. It, lab test says if you have ketones in the blood, you're not normal because nobody has
Going off
ketones in the blood if
going
they
off of
eat
that, could
carbs.
you explain
So
which biomarkers you look at? You can complete your train of thought there, but I'd love to hear from you which biomarkers you look at and which ones that change for your patients that are a little bit different than a standard patient.
yeah, as I get older, I and seeing things. come and go and worry and then not worry. I don't worry too
Okay.
much about what's in the blood. Remember, you can change your metabolism and change your blood by what you eat. And instead of kind of, uh, how should I say, justifying the consumption of carbs, well, you don't have to limit carbs, you don't have blah, blah, blah in the blood. Well, that I don't think that's the way to go about it. It should be, let's have real food that's really low in carbs, see how the blood looks, then add back carbs if you want. Even if you grew up with, I have trouble not eating chocolate croissants because I was in France when I was in college and I like them, but I don't eat them very frequently because of what it does to my metabolism, not by any specific number in the blood, because these things come and go, but because I know that eating the carbohydrate is pro-inflammatory, and so really the questions for me are: is it better to be in ketosis all the time or not? And I don't think we have good data on that. So I know lowering the carbs is generally a good thing. And I can't think of really any circumstance where telling people to eat real food without sugar
Hmm.
is bad for them. And now going back to this Jeff Volek again, the ketone metabolism is sort of like the fundamental way we exist when there's no food around. So if someone comes to me with reams of blood markers, and I have this happens all the time, it went from the LDL calculated on the lipid panel, LDL-C. It's not even a direct measure of LDL. I mean, that when I learned that, that's so you can alter the LDL by lowering the triglyceride because the LDL is a function of triglyceride, you know, divided by 5 in the Friedewald equation. So 15 years ago, people started using the NMR lipoprofile, which is in the lipid subfractions. There's another VAP test or other names for the tests. People started talking about the large and the small LDLs and the inflammation, the CRP, all these other things. And none of them really change what I recommend to people. So actually, probably the best marker, if someone wanted to add back carbs, I would say let's watch your triglyceride. If you can get away, so getting back to defining levels of carbs and low carb, 150 grams of carbs per day or less. Low carb keto is going to start at around 50 grams. And then low carb keto, where I know everyone will be in ketosis, is under 20 total grams per day. So that's sorry, I got back
I
to
appreciate that. We never got the
defining
answer.
low carbohydrates in terms of total grams of carbohydrates. So when someone comes to me, I start them on the 20 gram or less. And that's what the idea of, and I'll ask people, well, if someone says, do I have to do this? So it's extreme. I said, well, do you want to be sure to use something that works? Or do you want to diddle around and maybe do something that doesn't work? Well, I don't know. It took me 3 months to get into this appointment. I want it to work the first time, every time. Okay, then we'll use 20 total grams or less. And actually, it's easier in many ways because you're just not craving any sugar or starch. If you stop them all, you don't crave them. If you don't give up the fruit, for example, and you give up
Mhm.
everything else, you'll crave the fruit. And so there are even trigger foods which you might not predict. Nuts are trigger foods, and many people can't stop eating the nuts because they can be purchased in these big vats, and people can just over consume them. If they had to, open a walnut each time or pecan, then okay, maybe you can have nuts because they're a pain. Even pistachios, I can open up lots of pistachios out of the shells if I really want to. When no, it's really more of a I can't help it. I want more. It's a compulsion of eating there. So it's interesting to teach this and to have people have success. And it's not for everyone. In fact, so in an obesity medicine practice that I have, I focus on the keto diet. And so I turned the name of the
Hmm.
clinic into the Keto Medicine Clinic, kind of as a statement that it's really what I want to focus on. But people will come back and say, I just can't do that. I said, well, like riding a bike, want to get up and try it again? And some people just look at me and say, Doc, just give me a pill. Yeah. Okay. I'll give you a pill. So I still add some pills and occasionally one of the newer
Yeah.
shots. I'm
Tell
still
me
a
your
little leery of them. Some
tell
of
me your
them
thoughts
are
about
quite powerful.
Ozempic.
Some are very, yeah. Well, so I've been using a low carb keto diet, which actually has its basis 150 years ago before there was ever an Ozempic shot. So just you
Yeah.
don't need a shot to lose weight. There are other methods. So prescription diets, I think, are the first place to start. And if you're a doctor and you ask, well, what have you tried? People will tell you, I've tried everything. Yeah, you can't believe that. Come on. And even if someone said, well, I tried Atkins, I said, well, how was it? People think, well, it was great. I lost 20, 30 pounds, but then I went off it and gained it all back and more. And just expect that it's not true, but it's what they remember or perceive. And then I'll go back. Well,
Mm.
see, when you did it, it worked, right? And so you found out what works for your body back then. Let's do that again now with the science behind it to take away fear of any kind of blood thing that all those different fears. Take away the fear of eating fat, and my happiest patients are the ones I get off insulin. Nobody wants to shoot insulin, and even uh, but if you have a medical issue that no other medical doctor has been able to fix,
Yeah.
consider changing the food. So there's just some really remarkable dramatic stories. Well, I see that pretty much every day in my office. And someone just contacted me recently, again, from a different state, said, can I come visit your practice? People, you said that at a meeting. Is it still true? It's yes. The way I learned about this as a doctor was
Yeah.
to visit another practice. And I learned now in retrospect, I learned from the
Right.
world's expert. That was
Just
Dr. Atkins. Even though a lot of people thought he was
yeah.
crazy, he was just ahead of his time, or behind the. He stuck to something again that he knew was working, and then the world got all upset about fat. They
Yeah.
went to
Just to
work
jump
every
in.
day seeing people get better,
So it
despite
sounds
the.
like Ozempic can be a good tool or can be a tool, but isn't necessary if somebody truly sticks to a proper keto diet. The challenge is actually sticking to it. I know I've had a patient last week that was type 2 diabetes. I referred to a dietitian, and I always struggle with some of those referrals because I know they always recommend like somewhat higher carbs. But he's changed his diet. He's exercising, not a lot, but exercising. He's like, Doc, like I've been trying everything and I can't lose weight. Could I try Ozempic? And I encouraged him to continue the lifestyle modifications rather than jumping to Ozempic right away, because that's always my push. And I explained to them the rationality behind that. And so if you want to clarify that later, you can. And then the other question I wanted to ask is, based on your experience, what are the medications that you see people come off, and do you see them come off in a certain like a timely manner? So you put somebody on that has insulin on keto. Are they reducing insulin or coming off of it within a couple of days or weeks? Could you elaborate on that?
Yeah, of course. So in that case of your patient who came back, I would say, because you're busy, you're a family practice doctor, internist, you're doing all these other things.
Yeah.
Just send them to a book. Say, have you looked at that book by Dr. Westman called End Your Carb Confusion? I highly recommend it. Start with that phase one, and then you're done. You have just saved that person going to the dietitian, talking about eating carbs and all that, and it takes no time off you. So why not choose an approach that's been studied for over 20 years? There's a clinic with it. So if I could go back and I was just, I was not going to be a nutritional doctor or whatever you want to call it, I would have a book on my shelf, and I would say, "Hey, you see this book? Now, I'm not going to give this to you, but go out and buy it. It's $20. Follow it. You'll get a percentage of folks. I don't know what it is, 20, 50%, who go off and they'll do it. They'll do what you say. It occurs to me that most of my patients are doing what they're told, but they're given something that doesn't work. And I hate to tell you this because you probably believe it, but you don't have to exercise to lose weight. And in fact, sometimes that stops the weight
Right.
loss because it makes you a little hungrier. And if you're really dwelling you're close to the energy in and energy out, you exercise and you eat more calories than you're burning, you're actually going to gain weight when you exercise. Not on a keto diet, but so the other thing about a clinical practice like mine, most people who
Yeah.
come to me cannot exercise. They have bad knees, they're pre-op for knee replacement. And so what I do is 100% diet. That's another meme out there. It's
Yeah.
80% diet, 20% exercise. No, no, it's 100% diet. You don't have to exercise to lose weight. And while people don't always hear that, they'll say, look, you proved it. You've been working harder and harder and harder and exercising, and it's not working, is it? Well, no, there's something wrong with me. People will blame themselves often. I say, no, it's because exercise doesn't work. So in a clinical practice like mine, I was just told the average number of medicines for someone who's 60 in the US is
I
7.
can believe it.
The
Yeah.
average. I believe it. I mean, people come to me, it's the best medication program in the world, our medical care, medication care. So that, yeah, the only time I worry about friends and family doing this is if they're on insulin or other injectable diabetes medicine, because you match the diabetes treatment to the carbs that people consume. And so if I'm taking you from 300 carbs a day to 0 or 20, it's almost 0, and you're on 100 units of insulin and you have pretty good control,
Hmm.
you're going to have a hypoglycemic event, and you're going to be mad at me and say it was the diet's fault, when really it was the over insulinization, it was the over medication. So I will advise people with fairly good blood sugar control to come down 50% on their insulin on the first day. Often that's just taking away the short acting. So many people in my area are on a long acting and then they're on a short acting per meal. And I just explain, well, you're not eating carbs at the meal, so you don't need that short acting. The short acting is covering the carbs. They say, oh, yeah, that makes sense. Then it turns out they're on about half, 50 of the long acting and 50 of the short acting. And, they'll talk elaborately. I mean, these endocrinologists, I think this is all they do, or they like to fine tune that. And my endocrinologist says, if it's this, you should go up 2 units and this. And I'm like, no, 50%. So I had someone who was on 400 units of insulin a day. She was on the super
Hmm.
concentrated insulin because you run out of room for the shots, right? We did a food delivery program where we delivered on Saturdays lightly expired frozen foods just to teach people for 8 weeks what to do. And she was the home run of our pilot study. She followed it. She was
Wow.
off her insulin in 8 weeks, 400 units, and she'd been on insulin for 20 years. So basically, the medications for diabetes are treating the carbs in the food in most cases. Not all. If there's a lot of insulin resistance behind the scenes, you're going to have to get that weight loss too. But so diabetes medicines come away. I just through modern technology with cell phone every other day blood sugar. I took someone off about 60 units of insulin in a week, and the motivation for him
Mm.
was he lost 2 toes to diabetic neuropathy and foot ulcer. So the best medication care in our area, we're not a third, Raleigh Durham, you might not have heard of it, but it's actually, a metropolitan area. We have great doctors and the best medical care for this
Mm.
otherwise kind of wealthy guy. The downstream consequence of a hemoglobin A1C of
Yeah.
7, which is acceptable,
Yeah.
was losing 2 toes. So that was the wake up call. He's a kind of gnarly guy. You might say he was, a pirate or something. He doesn't want to always follow the rules, but getting your toes lopped off, he's, came to, okay, I'm going to follow this. And he's off all of his insulin in a week by me getting one email or text.
Yeah.
Takes me, 30 seconds. Now there are telemedicine doctors and companies that will follow thousands of people, kind of like a security system. And if the blood sugar goes off or too low, they'll get an alarm and they'll call them and say what's going on. So the technology is really great. And that person who took herself off insulin was using finger sticks. So now imagine, you have to prick yourself and get the blood glucose. If you have a CGM on your arm and you have your cell phone going like this,
Yeah.
your blood sugar every 5 minutes. And now there are a couple studies where all they did is give the CGM, the continuous glucose monitor. They didn't really tell people what to eat. And people naturally reduced their carb intake because they saw that when they ate bread, their blood sugar went up. So diabetes medicine, give me 2 weeks, the heartburn medicine is gone. And there is no randomized trial, but our proof of concept study with pH probes just
Oh,
showed that the acidity went down in 3 days. And the clinical, we took the worst of the worst, sickest of the sick, as a place to start a study of something that people think is
yeah.
terrible because nobody else wants to deal with it. So these people were refractory to proton pump inhibitors with their heartburn gone in 3 days in that study. But in my clinic, give it about 2 weeks,
How
and all
much?
of those heartburn medicines will be gone. The arthritis improvements. Oh, final one is the blood pressure medicines will come away, but that takes longer. It's not quite something I
Okay.
worry
How
about
much
like the
did the
diabetes
stomach
medicine.
pH change?
That's a great question. I don't remember the number. So Greg Austin, you could go to PubMed, Austin G, Westman EC, and I could probably, I
Oh,
don't
no worries.
technology limited on this screen, but Greg Austin was a GI fellow.
Would you briefly be able to just list off, you don't have to explain it, but a couple of things that you see the keto, the carnivore biohacker space get wrong? You mentioned early on issues with seed oils and the cold therapy. Like, is there a list that comes to mind where you're like, you know what, we don't have solid data to truly hate on these things or be worried about it?
Yeah, well, you named two of them right there. It could be though, in my program that I teach, or inherited through a clinic that worked out the kinks for 30 years, they never talked about seed oils. And it may be that the amount is so small when you eat a low carb diet this way that it's negligible.
Mhm.
So I don't worry about carblets. The idea that there's maltodextrin in the cheese to keep it from coagulating, but it's less than 1 gram per serving. So I don't worry about these little carblets. It's grams of carbs. And the unlimited fat idea gets a lot of people in trouble when they're trying to lose fat weight off their body. And then these all other biohacking things, for some people, a CGM or the quantified self knowing numbers is really helpful. But for some people, it creates
Yeah.
anxiety and is not helpful. So the worry about a blood number, as Steve Finney taught me years ago, again, he's one of my teachers, he said, we
Hmm.
measure the blood because it's convenient. It doesn't always tell us what's going on. And he used the metaphor of the blood is really like a medieval town road. People used to throw out the waste out the window, and because we have waste going through our blood, and yet people are traveling with bread to people through, and you avoid the waste, and so to just measure the keep in mind, well, we obsess over it because it's so easy to measure. It doesn't always give us good information.
All right. Well, appreciate very much. Thank you for your time, and we'll definitely have to set up another like a part two. And yeah, take care.
Well, my pleasure, and I'm so happy you're doing this and learning, and what you eat really matters. I'm waiting for the medical student to school, or the dean of the school, to get up the first day and say, what you eat matters,
Yeah.
and then he just leaves. Or everything you should learn about the human body needs to be colored through what you're feeding it, what the nutrition is, and I think great new discoveries will be made.
Yeah. I think we're making progress, but we're still a long ways away from that being the commonality. Anyways, I think I appreciate all the work you do, your YouTube videos and your books. I'll definitely recommend. I've already recommended your podcast, your YouTube to some patients, and
Fantastic.
I'll recommend your books as well.
I'm glad it's helpful. So keep it up.
Take care.
All right.